collection, result interpretation, then finally you prepare the report. So all these stages we involve the community group together. So then because without their support, I think it's hard to organize all this activity and data collection. Another thing is clinical field test is important to validate the self-exposure. So it's possible we recommend to doing the immediate, the clinical field test, just immediate after the disaster. Finally, IAB is so important. So because IAB normally review takes about months to finish. So in a state health department, I used to work there for 25 years. So I think in September 11 disaster and Hurricane Sandy, the IAB have some, they call a fast track IAB approval. And also they schedule a special IAB meeting after each disaster. I think it's very effective and helpful. They quickly shorten the time for the IAB review. And by working with health department also is another advantage because we should use the unique strength of the state university because half of our faculty is from state health department. So we should use the multidisciplinary research team to integrate the multiple expertise. And because each health department and also each county have, even have county, right, might probably know about it, have a disaster preparedness program. And our university have that too. So we should work together with those disaster preparedness program. And the database and technology infrastructure, and we should know what kind of data is available in state. I give some example, like sparse data is the one I use a lot, like include ED data and also admission data. And also I learned that there's a health emergency response data systems, hospital available bed data, and St. John means surveillance systems. I think it's for city and state have that one. It's the 24 hours reporting and biomonitor surveillance programs. And some of the data in our Wadsworth lab, they already collect for biological samples, they have been archived. So we probably can be able to use that to expand in the future as a background information, as a reference group. And finally, having some of the template for the questionnaire and also guidelines prepared in advance will allow us to have a more efficient epidemiology response to the future disaster when the disaster comes in. So, yeah, stop here. Thank you.
Thank you, Dr. Lane. So our next speaker is Dr. Samantha Painter.
All right, thank you everybody for being here today. So I'm going to be doing something a little bit different from my fellow panelists. So instead of talking about a specific experience, I'm going to do a little bit to set up this idea of interprofessional collaboration and its importance. I'm going to use some examples from research I did studying international crisis medical relief to illustrate some of the obstacles or issues that can emerge in this interprofessional collaboration in disaster medical care. And then end by using that as a launching pad to talk about what the literature suggests might be some effective techniques that we can use to start helping to prepare our future generations of emergency medical workers or emergency managers for this interprofessional collaboration. So I'm sure this is of zero surprise to everyone in this room, right? But the complexity and scale of the challenges that we're facing requires collaboration across disciplinary lines and professional lines. And especially in the healthcare context, we see that this increasing specialization means that no single person, no single discipline has all the answers to address these increasingly large and complex problems. So we can think about expertise in a couple of ways. Right? So we can think about expertise in terms of that discipline-specific knowledge. Right? We go to school or have specific training that teaches very specific knowledge and specific skill sets relevant to those domains. But then there's also some context-specific knowledge that can be incredibly important in the disaster context in particular. And especially what I want to bring your attention to here is the role of logistics in facilitating emergency medical relief, crisis medical relief. Right? So in this context, we have people who might also need to take on roles that are slightly different from their normal operations and thus require an expertise or require a skill set or knowledge base that's a little bit different from what they're regularly trained to do. So we can think about this as the difference between providing healthcare in a normal hospital context under normal conditions compared to providing healthcare in a hospital that's under extreme stress from being in a disaster, so resource constraints, but still in that hospital setting, compared to providing medical relief in a mountainous rural region you can only access by foot and has very limited resources, right? There's different contextual information there. And so some of the issues that can come from this interdisciplinary collaboration were highlighted in some interviews I did with folks involved in planning and implementation of those efforts. So this is an example from a senior level person in CDC who was involved in the Ebola epidemic. And he talked about the need for greater investment in data management, right? So they were thinking about the epidemiological process, but they weren't necessarily thinking or as focused on some of the logistics infrastructure that they needed to have in place to do so. This example is taken from a logistics-focused individual from Team Rubicon working in the Nepal response. And he was telling a story of some physicians who had joined their team to help deliver care in a very rural area of Nepal, mountainous, difficult to access, and they were dressed in windbreakers and day packs, right, which wasn't really appropriate for the area where they were going. And this individual stepped up and pointed out that there was an issue. And in his discussion with me, he mentioned that the medical field forgets how important logistics is, and that they were thinking, what do I need in my pack to help those people, instead of what do I need in my pack to help me so I can help those people. I'll just briefly go through two other examples. So in this case, also from Nepal, there was a physician team leader, and they were talking about how to provide some healthcare services in this context in which they didn't have a physical structure to operate in. And a colleague on the team, who was from a different field of medicine, she was from obstetrics, was talking about using one of their private tents for the relief team to provide a private space for OB exams. And at first, this interviewee was like, well, those are our private tents, right? We can't do that. But then realized, oh, this is a great idea, and we should do this whenever we're not working in a structure. And then the last example I'll highlight here comes from a person who was trained as an emergency manager working in CDC during the Ebola epidemic. And he talked about the process of making decisions. And he said that as an emergency manager, he was trained that if he only had 50% of the information and he needed to make a decision, he could make a decision, where many of his medically trained colleagues had a much higher threshold of information need before they could make a decision, and that presented some obstacles. So really we can water a lot of these obstacles in interprofessional collaboration down into being focused on different kinds of information, both problems and potential solutions, right? And then also having different approaches to handling these interactions, handling these problem-solving elements in and of themselves. So this is the part where we go back into the literature, because the healthcare sector has actually been looking at interprofessional collaboration for a little bit of time now, and they've identified several things that can help facilitate this interprofessional collaboration, looking especially in the context of doctors, nurses, social workers, therapy, right, those different kinds of healthcare specific actors. So clearly building professional and disciplinarily diverse teams is helpful, right? People are now becoming aware of things that weren't on the radar before. It's more comprehensive. But an important part of these teams and making them functional that's highlighted in the literature is role awareness. So everybody on that team knowing what everybody else's job is, where someone's job starts and someone else's job starts, right? Knowing what those boundaries are. And then related to that is having a respect and deference to that expertise. So recognizing when someone else actually is more familiar with that particular knowledge domain, and then deferring to that expertise instead of stepping in an area in which one doesn't have that dominant knowledge. This is also echoed actually in the disaster literature on high reliability organizations, which are characterized by what Wyatt and Sutcliffe say is pushing decision making down and around. So the idea that the people who are making decisions aren't necessarily the most senior personnel, but they do have the most relevant expertise to be making that decision. Communication is clearly highlighted as important in terms of navigating some of these issues. And what especially my work has highlighted is this idea of being able to identify when a context has altered what that relevant knowledge is. So essentially, when we're talking about facilitating interprofessional collaboration, we're talking about having people who can identify when someone else has more relevant knowledge to handle a particular issue. And that's definitely something that emerges in that healthcare literature. But something that I think is a little bit understated, but is equally, if not more important, is also knowing how to intervene when someone who lacks that relevant expertise is now making a decision or stepping into an area which they might not be best suited to handle. And this is really important because there's also a lot of things, particularly in the social science literature, which highlight why that can be very challenging. So this can be issues of hierarchy and structure. We know stereotypes can come into play, status role expectations, other sort of stereotypes or assumptions around professional roles and identities, which means that we need to work with people to help them learn how to handle these situations. And really here we can talk about the role of interprofessional education. And I'm really excited about this opportunity to talk about this at this conference, because here's where I think universities can come to play a really important role. So again, in the healthcare context, there's been some discussion about how we can integrate interprofessional education into things like medical school training or nursing training. And the idea of that if we can equip people in their professional education to do this, they'll be able to actually do this in the field. I would argue a few things from this. One, that we need to now be thinking about extending this beyond the healthcare sector in a couple of ways. So first, that healthcare workers should not just be trained to work interdisciplinarily with other healthcare workers, but also be trained to do so with logisticians, with folks that might not be directly involved in patient care, but can be tremendously important in facilitating the provision of those services. And then also this is something that we should be thinking about incorporating into emergency management education as well. Now, the research in healthcare interprofessional education has identified, is sort of still figuring out how best to do this, has identified some things that can help or make this education more or less effective. So it's pretty clear that students have to have some skin in the game in this process, right? This isn't something you can have a 1-hour online course and then suddenly everybody's good at working with everybody else, right? They will invest time in learning what's evaluated, what's a consistent part of the curriculum. Something else that's important here is also that we're sending a consistent message about how it's valued. So there's work on the hidden curriculum, particularly in medical education, that talks about how implicit messages that come from interactions with faculty outside of the classroom or even in things like their residencies can sort of subvert some of the explicit messages in formal curriculum. So as important as experiential learning is in this field, we want to make sure that our students are getting consistent messages about the importance of being able to work with people in different fields. So with that, I think I'm within my 10 minutes, and I look forward to talking more about this in the Q&A. Thank you for your time.
I love that when we talk about the importance of logistics and team dynamics during emergencies. I know Seth and Mike know how important that is as emergency managers. Our next panelist is Ms. Mary Riley-Jacome.
Thank you so much. Thank you, Shao, for inviting me to be on this panel, and thank you. The discussions have been great. I feel like I'm building on a couple of them, and so do you want to time me also? Because I think I'm over, but since people have touched on some of the other ones, I can skip. Can I just ask the audience, how many people are in a healthcare or public health role? Most, but there's some great. So basically, the Center for Public Health Preparedness, the role really has been to translate the research into training and ways to practice it so that we can improve emergency preparedness and response for the public health workforce. So I really just want to talk about some of the research that we did that is applicable to trying to engage communities, either pre or post disaster. So the first one was Latinos during emergencies. It's cultural considerations impacting disaster preparedness. And for this particular training, we brought together some research done by the National Council of La Raza. They developed this awesome emergency preparedness, emergency managers toolkit for working with Latino communities. And the toolkit really has some steps, about how to engage, who are the leaders, what communication channels are you going to use, what's the messaging you're going to use. So, and that particular toolkit, while it's great for Latino communities, it can also be applied to any other community you're working with. And as we know in New York, if you're in New York City, it's completely different than if you're in upstate New York and what part of upstate New York you're in. So learning to understand the community is really important. And the second one is a psychological first aid training. Does everybody know what psychological first aid is? So psychological first aid is an evidence-informed approach that provides staff and volunteers, or everyone, with practical ways to help people with basic needs and immediate concerns during a disaster. It has also been used for violence in Ireland. It's been used for crime victims in other countries. So it really is some great, very simple tools to sort of help people start to recover or help to support them recover. And so with this particular project, we did a collaboration with the Institute for Disaster Mental Health, New York State Department of Health, the Office of Mental Health, and our partners in order to develop a training toolkit so that organizations could build capacity to develop and implement policies and practices to train their workforce on PFA. And as part of that, we developed some scenarios, for example, for people who would, who might be trying to encourage an elderly person to leave their home when they don't want to evacuate, or somebody who has Alzheimer's disease in a long-term care shelter and has to be evacuated. And what are some of those things, or an active shooter event? And those were used in order to build those skills and competency at the individual worker level. So, what basically our goal has been to be, what's the research? How can we effectively translate it into training or to action? Why is it relevant? How can we communicate it? And who needs to be at the table? And as has been discussed, there's a lot of research already out there that has been implemented and has had an important impact. So this is just one little example. I completely forgot that second piece of the the Latinos. Dr. Blanca Ramos, who's a professor here at the University of Albany School of Social Welfare, did some research on post-earthquake recovery and resiliency, both in Peru and Turkey. And she looked at the cultural values that fostered resiliency. And a couple of the values that she really identified is that in the community in Peru, that people really identified with anything that was going to help the community or help the family over helping the individual. So she suggested, targeting any messaging sort of toward the community and toward the family rather than to protect themselves. And so this was just one example of that. So, has anybody seen the movie Farewell? No one? Okay. Well, oh yay! I wanted to do a shout out because it's one of the stars is the U Albany graduate, Aquafina. So good reason to go and see it. But also, the Farewell provides an example of the role of culture plays in healthcare and family dynamics. And also, we know that culture plays a role in how people respond and perceive traumatic events. So it's important both for us to understand the culture we're going into if we're being deployed to an area, and also that psychological effects can be different depending on the community. And so it's important here, and I understand that there were some cultural challenges from the hospital side that was deployed from here. They had mentioned that there were people who needed, different from what you said yesterday, but there were people who needed a higher level of care, but their family members wanted them to stay in the community. And the only way they could evacuate them for a higher level of care was to the ship, but that meant that the family member had to accompany them as well, and so that they had to do the logistics for the family member that was going to be medevaced on the helicopter, and they also had to provide for that person if they were on the ship. So those resources of room and board, that might have gone to someone else, had to be taken into account, so that to understand what the cultural issues are, so that you can better plan and provide. are important. And it's also what Dr. Ramos found was that, you know, culture did have an impact on resiliency. And so, again, how the family and community benefit was particularly useful in Peru. There was some indication that post-Hurricane Sandy that the Latino community did sort of embrace Occupy Sandy, which was doing community level work. And so there may be an indication there. And this is just one of my favorite words, it's Aminga. It's in Quechua, that they use it in the Andes of South America. But really everything is done by collective effort for the common good. So if they're gonna build a health center, a water system, a school, everybody has to agree to that, and then everybody has to give some time digging ditches and whatever else it is, so it's a collective action. I am gonna shift for a second and go on to some of the building partnerships. Oh, so the reason, so those are some of the trainings that we have done prior to an event. So we're working on trying to get people trained beforehand. But there are a lot of resources out there so that if you get deployed, because obviously you're not going to know whatever community you go to, there's going to be people who are different than you are. The state has some programs on working with special needs. City has a lot of stuff with working with different religious groups. DOH and all of the local public health have done a tremendous amount of work working with local communities, you know, on the measles campaign. Red Cross has a bunch of programs working with different people, but there are some resources out there for if you're going to work with a Buddhist community, or if you didn't get our little psychological first aid cards, there are a lot of resources, the Emergency Managers Toolkit. So in New York State, and I guess most of the country, we have these regional health emergency preparedness coalitions. And basically it's the hospital and the local public health, emergency management, EMS, and sometimes, and 1 or 2 minutes, okay, I'm gonna do this quick. Volunteers active in disasters. And so when I asked some of my colleagues about how they thought there might be some improvements in this, I said there is some, there's some flexibility in the model, so you can include partners that you'd like, you know, from your area, so which is great. So Central New York, I think, has like, they've done more work with building refugees and faith-based communities. Those collaborations in our area tend to happen more at the local level. So Albany has done a lot of work with the Karen refugee. Rensselaer County has long-term care, and universities and colleges in Rensselaer County on their committee. So they just said that in general, it would probably be better if we had some consistency in getting more of the community health centers and the mental health clinics involved, because they're outward facing and they have those community contacts, so they would be a tremendous asset in any event. And then Mike already mentioned the home care folks that are out there on their own. And I just wanted to say, not only just for that, this model's been great, we also know that everywhere, no matter where you are, maybe minus New York City, you're gonna have some regional and local gaps. And so in our district, we've looked at seeing what the gaps are. We know that we only have one pediatric intensive care unit. And so what they've done is every year we have a conference or seminar we train. So it might be pediatric decon, it might be pediatric disaster mental health, but we're trying to build the capacity of everyone is in the area. And then the last question, which is part of the panel, was who else needs to be at the table? So it really depends on what your community is. Speaking to Mike from Red Cross, and they're building some training modules on working with specific communities. I happen to work on an Alzheimer's Association grant, Alzheimer's disease grant, and they had mentioned wanting to reach out and do more training to faith-based. And I said, well, why don't you contact the New York Disaster Interfaith Services, because helping them train on Alzheimer's disease and dementia may help them serve better when they respond to a disaster. It also may help them identify more people that will send to you, so there can be some mutual benefit. And one other example is when we've done a lot of training and exercises in the community and bringing in those people that usually don't have any emergency management experience or any role. In one case, they just brought in one child care center, and we're doing a shelter and evacuation tabletop exercise, and the person said, well, you know what, we can't evacuate people. We don't have the children. We don't have permission to take them in a car. We don't have car seats. Something as simple as that is getting them, thinking about that. And the only one on this one I'm going to say is the response team makeup. I had a suggestion from one of our colleagues that the response team shouldn't have just clinical people, but maybe some non-clinical people that can work on, the engineering or IT or the language piece. So, thank you very much. Appreciate it.
Thank you, Mary. So our last speaker is Mr. Stuart, and Neil Stuart from National Weather Service.
Hello everyone, so this is going to be a big shift from what we've been talking about over the last 5 presentations. However, it's still applicable. So, so after all this, long-term planning and all this, all this planning and working with communities, we in the National Weather Service actually provide the weather information and the predictions so that once the disaster is actually on the radar and looming in front of us in 7 days or less, we provide a lot of the weather information so that the disaster plan can go into action. We can all take care of what we need to take care of to all the people in the communities. So I will go through a few of those resources for those who are interested. But again, we also provide a lot of the impact decision support services is most important. However, we do work with communities and help them to do training exercises for disasters so that they can be prepared also. So we're part of that equation too. So let's see here, I'm guessing the arrow keys will, yes. Okay, so one resource that a lot of government, local, state, and federal government officials use is a program called HUREVAC. And maybe you've seen some of these graphics on television or in the social media where you have the cone of uncertainty. So I zeroed in on Puerto Rico, and you can see that for Hurricane, I believe this is for Hurricane Maria. Of course, the cone of uncertainty was the line, the center line of the track was actually over Puerto Rico, but anybody within the cone of uncertainty should be aware of the potential for a hurricane, and this forecast is actually 5 days out. So again, a lot of times you can have 5 to 7 days of lead time to begin preparations for these types of disasters. The National Weather Service in San Juan provides some great resources also. So once a hurricane, again, is on the radar and is looming in the distance, we have local National Weather Service offices. Of course, I work in Albany, and there are 122 offices across the continental U.S., and there's an office in San Juan. There are offices in the Pacific territories, Alaska, Hawaii, so there are offices that provide localized warning information for local communities and residents to use. And what's great about San Juan, of course, is that they have the exact same information in English and in Spanish for those who require Spanish. So here is a forecast graphic from the National Hurricane Center, and they're a great resource for a lot of weather prediction information. This is a forecast showing the probability for tropical storm force winds and the times. And I have Puerto Rico circled. And this forecast was issued at 8 p.m. on Monday. So this is a 2-day forecast saying that you will almost definitely have tropical storm force winds within 2 days, around 8 a.m. Wednesday. So we can provide that sort of specificity with wind forecast and timing. And here's a graphic showing a prediction of hurricane force wind probabilities for Puerto Rico and Maria. And again, almost a certainty, more than 2 days in advance. So again, so people can prepare for the worst of conditions even days in advance. This is a rainfall this is actually showing the amount of rainfall that fell in Hurricane Maria over Puerto Rico. And note that, of course, in the higher elevations where there's some terrain, you get some extreme rainfall amounts in hurricanes. In fact, there was over 35 inches of rain in a few points in some of the mountains of Puerto Rico, but a very widespread over 20 inches of rain. And of course, landslides and freshwater flooding is another big problem in these tropical systems. But the Weather Prediction Center actually provides rain forecasts. And this is not showing a hurricane rain forecast, but it shows that they actually do focus on the Caribbean, including Puerto Rico. So if a hurricane were to threaten, you would see precipitation forecasts out to 3 to 5 days. So again, you can anticipate the potential for landslides and freshwater flooding in advance of a hurricane. Now, most recently, this year, the National Hurricane Center has been actually providing value-added information to some of their hurricane graphics. So for Hurricane Dorian this past summer, the Hurricane Center actually provides a general description of what the conditions are expected based on their predictions of hurricane force winds and other things with the specific timing of when those conditions will be expected. So if you were to go to the Hurricane Center website, you would see, again, this value-added information to describe what these graphics are showing. And then that would prompt you to go to your local National Weather Service office and get more specific information. Now, in terms of some of the information that we do provide from the local offices, of course, is evacuation information, and how to get resources and what sources of information to get their information from. But there was a poll actually done after Hurricane Katrina that determined why people didn't take what they figured were the correct actions to protect their lives and property. And a lot of people thought that it wouldn't be as bad as predicted. A lot of people didn't want to leave their families. There was not enough transportation. They couldn't afford to evacuate. They had nowhere to go. They had to work. There were underlying health issues. They didn't want to abandon their pets, and some were just simply stubborn. So again, the information that we provide from the National Weather Service does actually address some social science issues. So some of the messaging that we do provide do try to get into the social science and the thinking and some of the issues that people have in terms of to motivate them to make the right decisions. There are hurricane safety websites within the National Weather Service also, and there's a lot of really good information, including outreach and education. So prior to these disasters, we actually have information from our federal government websites, from the National Weather Service, that provide outreach information, including brochures that we can give to people and give communities. If we're doing outreach events, we'll have lots of brochures and lots of information that we offer people so that they'll have that information on hand to make their decisions when a disaster threatens. And I circled the fact that we also have all these brochures and outreach information in Spanish, which is good. So there's also an actual hurricane preparedness website, specifically just for hurricane preparedness. And there